Hello, my name is Neetu. Today I am presenting this case of my patient with an acute musculoskeletal complaint seen in a primary care clinic. My patient identification: the patient is 58-year-old Hispanic male. I refer him as Mr. J to protect his privacy. He presented to the clinic with a new complaint of acute lower back pain. His chief complaint was that he stated that my lower back has been hurting for past several days. MJ is a 58-year-old male who presented with approximately 5 days of lower back pain. His symptom began after several hours of a heavy physical work at home, and he said he was involving in a repetitive bending, lifting, and twisting. He denied a fall or any direct trauma or other specific injuries. He described the pain as a constant aches and in the lower lumbar region, rated 6 out of 10 numerical pain scale. The pain is worse with the forward bending, twisting, and prolonged standing, and getting up from a seated position, rest, and changing position, providing us some improvement. Importantly, he denies pain radiating into the either leg. He also denies numbness, tingling, weakness, a lower or bladder incontinence, and urinary retention, and subtle anesthesia. He denies a fever, chills, night sweat, unexplained weight loss, recent infection, or any histories of a cancer, significant trauma, or IV drug use. He also reported that he has been experienced this exact type of a back pain before. The next section is the pertinent medical history. The patient report no significant past medical history and denied a previous chronic musculoskeletal problem or similar episodes of a lower back pain. He has no known drug allergies. He occasionally takes over-the-counter ibuprofen 200 mg for his current back pain, and especially he works in a maintenance where involves a lifting, bending, and twisting. He is normally physically active, but his activity has been limited because of the current pain. He does not smoke and report any occasional alcohol use. Review of system: the most pertinent positive finding was localized lower lumbar pain that increased with the bending, twisting, and lifting, prolonged standing, and changing position. Pertinent negative includes no lower extremity weakness, numbness, tingling, radicular pain, gait changes, bowel or bladder dysfunction, urinary retention, subtle anesthesia, fever, unexplained weight loss, or other systemic symptoms. Objective findings: his vital signs are stable, temperature 98.4 Fahrenheit, blood pressure 128/78, pulse is 76, respirations are 16, and oxygen saturation on 98% on a room air. His BMI was 31. On examination, he was alert, cooperative, and well appearing, and mild discomfort during the position change. The focused musculoskeletal examination showed a mild bilateral lumbar paraspinal tenderness. There was no spinal deformity, bruising, swelling, or midline spinal tenderness. The lumbar range of motion was mildly decreased because of the discomfort, and particularly with the flexion and rotation. His neurological examination was normal. Lower extremities strength was 5 out of 5. Sensation was intact, and reflex were symmetrical. Gait was normal, and the straight leg raise test was negative bilaterally. There was no focal neurological deficit, no laboratory testing or imaging was obtained. Differential diagnosis: my differential diagnosis included the first one, lumbar radiculopathy. This was considered because the low back pain can be associated with the nerve root irritation. However, this is less likely because the patient has no radiating leg pain, numbness, tingling, weakness, or abnormal neurological finding, and his straight leg raise was negative. Second, vertebral compression fracture. This was considered as a possible secondary cause of the back pain, but was less likely because he had no significant trauma, no mild tenderness, or no history of suggestive osteoporosis or previous fragile leg fracture. Third is the spinal infection. This was considered because but was less unlikely because was a patient, he was afebrile, and he also denies any fever chills, recent infections, and also IV drug use, or he's not he has no other systemic symptoms. Further, fourth was a spinal malignancy. This was also considered but less likely because he has no history of cancer, unexplained weight loss, night sweats, or neurological abnormalities. Finally, the next one is a Quetta syndrome, was considered because of the soreness of the of missing this condition. However, this was highly unlikely because he denies a subtle anesthesia and urinary retention, bowel and bladder incontinence, and progressive lower extremity weakness. Assessment, the final diagnosis is acute strained muscle fascia and tenderness of the lower back. Initial encounter, the presentation is the most consistent with the acute mechanical lumbar strain. The diagnosis is supported by the recent repetitive lifting, bending, and twisting. Localized spinal tenderness, pain with the movement, and mildly decreased range of motion, and absence of radicular symptom, neurological deficit, and systemic symptom of the other red flags. Plan is, because there was no red flags, finding would manage the patient conservatively. No imaging or laboratory testing was indicated at this visit. Routine imaging is not recommended for uncomplicated low back pain without significant trauma, neurological deficit, or red flags symptom. For medication management, the patient is advised to take ibuprofen 400 mg by mouth every 6 to 8 hours as needed with the food, using the lower effective dose for the shortest appropriate duration. He was instructed not to combine it with any NSAIDs, contraindicated medication, and the consider contraindications such as kidney disease, gastrointestinal bleeding, cardiovascular disease, anticonvulsant use, or NSAID allergies. For non-pharmacological treatments, I recommend the continue a normal activity as tolerated rather than prolonged bed rest. He should temporarily avoid heavy lifting, repetitive bending, and twisting. Heat may also be used for 15 to 20 minutes as needed. Light stretching and a gradual return to normal activity was encouraged. Thank you for listening to this presentation.